Hi, everybody. This is Dr. Brett Talley Daniel, MD. I'm a neurologist and headache doctor. And today I'm talking on a sort of a confusing but very interesting subject called vestibular migraine. And I'm going to start off by defining some terms. So vertigo is a feeling of movement that comes from the Latin word which means to turn, and it's likened to the feeling one has when spinning around a number of times on a merry-go-round or something and then stopping. It's what one feels on the playground when you get off the merry-go-round. Although usually rotary in motion with the patient at the center, vertigo can be the perception of motion on the part of the patient. Thus, vertigo can be non-rotary, which includes a sense of linear or up and down movement. They have these terms called internal vertigo, which means a false sensation of self-motion, and external vertigo, which is a false sensation that the visual surround is spinning or flowing. Vertigo may originate in the vestibular branch of the eighth cranial nerve in the inner ear, or it's called peripheral or end organ, or in the brain, usually the cerebellum or the brainstem, where it's referred to as being central. And in general, something like 90% of vertigo is found in the inner ear. Positional vertigo occurs after a change of head position, and there may be then visual-induced vertigo triggered by complex or large moving visual stimulus. Vestibular symptoms are rated moderate when they interfere with but do not prevent daily activities, and severe when daily activities cannot be continued. Duration of episodes is highly variable. About 30% of patients have episodes lasting minutes, 30% have attacks for hours, another 30% have attacks over several days. The remaining 10% have attacks lasting only seconds, which tend to occur repeatedly during head motion, visual stimulation, or after changes of head position. So the question is now, what is vestibular migraine? Well, the International Classification of Headache Disorders, Third Vision, defines vestibular migraine as a 1.6.6 vestibular migraine, which has previously used terms. It was called migraine-associated vertigo, dizziness, migraine-related vestibulopathy, migrainous vertigo. The diagnostic criteria are A, at least 5 episodes fulfilling criteria C and B. B is a current or past history of migraine without R or migraine with R. C is vestibular symptoms of moderate to severe intensity lasting between 5 minutes and 72 hours. And D, at least half the episodes are associated with, or at least one of the following 3 migrainous features. They have a headache with 2 of the following 4 characteristics. These are like migraine features. One-sided, pulsating quality, moderate or severe on a scale of 1 to 10, they're over 5. Aggravation by routine physical activity. Number 2, sensitivity to light and sound. And number 3, a visual aura. All right, that's how you diagnose and define vestibular migraine. Related symptoms. Photophobia. Well, photophobia means light sensitivity, so the patient avoids the light, which worsens the headache. Migraine patients in general are sensitive to light mostly all the time, but during a migraine, the light makes it much worse. Phonophobia and sonophobia are similar terms that mean sound causes the head to hurt. Visual auras are characterized by bright, scintillating lights or zigzag lines, often with a scotoma or blind spot that interferes with reading. Visual auras typically expand over 5 to 20 minutes and last for less than 60 minutes. What is the examination for vestibular migraine? Well, there's a history, the physical exam, and neurologic workup, including ENT and neurologic consults, and they all should be normal. Testing such as blood work, an audiogram, vestibular testing, MRI scans or CT scans of the cerebral arteries, brain CT and MRI examinations, not all should be normal. Other symptoms such as short-acting auditory symptoms, nausea, vomiting, prostration, and motion sickness may be associated with vestibular migraine, but since they also occur with other vestibular disorders, they are not included as diagnostic criteria. Another definition of terms, the anatomy of vestibule refers to the inner ear. In Latin, vestibule means an entrance hall, so it's like the entrance into the inner ear. The vestibule is the part of the bony labyrinth in the inner ear situated medial to the eardrum, which is the tympanic membrane, behind the cochlea and in front of the 3 semicircular canals. There's a chemoreceptor trigger zone, which mediates vomiting. It's in the medulla oblongata, which is part of the brainstem. The chemoreceptor trigger zone is near the entry of the 8th auditory nerve, which carries hearing and balance information. In the inner ear, the semicircular canals respond to rotational movements like angular acceleration, and the utricle and saccule respond to changes in the position of the head with response to gravity, and that's called linear acceleration. So we have like this little motion detector in our brain, which is in the inner ear. Migraine with and without aura have a brainstem generator in the perioctal gray part of the mesencephalon near where the labyrinthine fibers of the inner ear connect. But migraine causes more vertigo than any other condition. The incidence of migraine in the United States is 12%, while the incidence of Meniere's disease is 0.2%. About 50% of patients with Meniere's disease have migraine. Neurologic practices focusing on headache report episodic vertigo in 27 to 42% of migraineurs. Dizziness, vertigo, tinnitus, which means ringing in the ears or sound in the ear, photophobia, hearing loss, and nystagmus may accompany migraine. Vestibular migraine may occur without headache. Typical acute preventive treatment for migraine may improve the migrainous vertigo. Now, migraine and vertigo have had a long personal relationships, and neurology textbooks the last 50 years, like Merritt's textbook on neurology, have all listed vertigo in a long list of symptoms associated with migraine. That's the book I was reading back in 1967 or so when I was a medical student and taking my neurology my neurology rotation. There's a large body of literature linking these two subjects. Many ENT and neurology articles are published every year on migraine and vertigo. Now, dizziness is a much less precise term than migraine. And it has a large group of different causes that can cause it. So dizziness can be giddiness, near faintness, swimmy-headed, off balance, or unsteadiness. And dizziness doesn't localize to a specific part of the brain, whereas vertigo is brainstem, usually cerebellum or inner ear. What are the causes of dizziness? Well, inner ear inflammation, hypoglycemia, electrolyte imbalance, low blood pressure, decreased cardiac output, anemia, anxiety or panic attack, hyperventilation, medication effect, or many other causes. So what is the clinical course here? Vestibular migraine is characterized by episodic symptoms of severe vertigo with or without a headache, which may significantly interfere with the patient's quality of life. And the symptoms are very life disruptive when they come, and oftentimes the patient is anxious and waits for the next attack with nervousness. Vestibular migraine is a chronic condition with attack times lasting months or years, separated by periods of normal health. Attacks of vestibular migraine may be familial or sporadic, and there's some articles I have on that. One article from Louisiana says there's a familial occurrence has been reported in some patients with an autosomal dominant pattern of inheritance and decreased penetrance in men. The genetics of vestibular migraine are heterogeneous and uncertain, but several studies suggest linkage to chromosome 5q35 or 22q12. Episodes may follow the usual migraine triggers of stress, overwork, anxiety, depression, insomnia, before or after stress, the so-called letdown headache, or fasting. Although all ages may be affected, it's usually worse for young adults. Vestibular migraine is underdiagnosed, yet it is the most common cause of recurrent spontaneous vertigo attacks. Now, the classification of vestibular migraine was not in the International Classification of Headache Disorders version 3 until several years ago, and it was accepted by that organization and the Bharani Society, which is ENT, as a diagnosis for vestibular migraine in 2012. Now, on close questioning, most patients can differentiate between vertigo and migraine. Complicating this situation, the fact that the occurrence of dizziness in the general population is over 20%. However, patients who have migraine with aura have significantly more dizzy spells than non-headache subjects. Dizziness is strongly associated with functional, meaning psychological medical problems, and it's one of the 13 classical symptoms of panic disorder. Migraine and motion sickness. Another interesting and well-known link to migraine is motion sickness, which usually comes on in childhood and improves somewhat with aging. The symptoms of motion sickness may be nausea, dizziness, vertigo, sweating, or headache. Commonly, children experience this in the back of the car when riding. It also occurs with reading in the car, participating in amusement park rides, especially rides with fast circular motion, and on boats and airplanes. Most studies report that about 60% of patients with migraine have motion sickness, while only 5 to 20% of persons without migraine get motion sickness. I was in the United States Navy as a neurologist in San Diego at the end of the Vietnam conflict and saw several patients who had motion sickness who were going on boats. And the Navy quite understandably and reasonably says that persons who have motion sickness are not fit for duty, so I had to board this gentleman out of the service. Migraine and vertigo incidence. Medical practice that specializes in migraine found that 27 to 47% of patients report episodic vertigo, and about 36% of these migraineurs get vertigo when they have no headache, while many others get vertigo either just before or during the headache. Migraine with aura patients have a higher incidence of vertigo during the headache period than those who have migraine without aura. The converse of this is that practices that specialize in vertigo find that 16 to 32% of the patients have migraine. Well, what's the relationship to benign positional vertigo? Vestibular migraine may begin at any age, while benign positional vertigo is a childhood disorder. Benign positional vertigo is diagnosed by 5 episodes of vertigo occurring without warning and resolving spontaneously after 5 minutes to an hour. Neurologic examination, audiometry, vestibular function, and EEG are normal between episodes. One-sided throbbing headache may occur during attacks, but it's not necessarily required. Benign paroxysmal vertigo is a precursor of migraine, which later develops more fully with aging. However, vestibular migraine does not have an age limit and may be found in children and adults meeting the proper diagnostic criteria. What about vestibular migraine and Meniere's disease? Migraine is more common in patients with Meniere's disease than in healthy core controls. Many patients have migraine, vestibular migraine, and Meniere's disease, which may be inherited as a disease cluster. In fact, Prosper Meniere had discussed migraine, which is present in many of his patients that he reported. Vestibular migraine may have fluctuating hearing loss, tinnitus, which is ringing or a sound in the ear, and an oral pressure, like the ear is full. But the hearing loss doesn't progress over time to deafness and be documented on audiogram, like with Meniere's disease. In the first year after onset of symptoms, differentiation between them may be challenging, since Meniere's disease can be monosymptomatic with only vestibular symptoms in the early stages of the disease. But with Meniere's disease, the clinical course is usually progression toward sensory neural deafness, usually in one ear, although it can come in both ears, coming through time with attacks of vertigo, ringing in the ears, tinnitus, and deafness. The differential diagnosis of vestibular migraine. This includes migraine with brainstem aura, ear infection, brainstem infarct, autoimmune inner ear disease, multiple sclerosis, early Meniere's disease, vertebral basilar ischemia, cerebellar tumor, and Arnold-Chiari malformation. The pathology. The relationship between vestibular migraine and Meniere's disease is uncertain, and particularly the onset of symptoms, it may be difficult to differentiate the two conditions. Treatment of vestibular migraine. For acute therapy, triptans to date have, with randomized and controlled studies, been inconclusive. Many headache doctors like to use one of the benzodiazepine drugs, which may work well. My own preference here is diazepam, the generic of Valium, 5 to 10 milligrams at onset, and then every 4 or 6 hours later. Nausea can be treated with antiverter, meclizines, or other drugs like that. You can use transdermal scope. You can also use Zofran, the generic was ondansetron. All of those work well for the nausea part. Medical devices. GammaCore, a handheld neck-delivered vagal nerve stimulator, may be tried. And Dr. Friedman in neurology in 2019 reported on their study using a vestibular stimulating study that had the results, which I'll quote, were they provide preliminary evidence that vagal nerve stimulators may provide a rapid relief of vertigo and headache and acute vestibular migraine, period, end quotes. What about preventive therapy? Typical migraine preventive drugs such as topiramate, amitriptyline, beta blockers, and Depakote, but not for in women who are fertile, could be tried, but there's little data on the success of this. I think this is my own personal feeling, my opinion. The drugs of choice likely in the future will be one of the CGRP drugs such as Aimovig, Emgality, or Jovi, but there's just no data on that. Now, if you go to my webpage on this at drmigraine.com, I have a long list of review of articles that support and as a kind of list of symptoms and literature on vestibular migraines you can look at if you want to. So this is the end of my report on vestibular migraine. Hope it helps you. Please click subscribe, and I'll see you again on another talk. God bless all you migraine patients.